Okay, I want to do a finish the recording of that class we started on cardiac anatomy so that we can cancel class Friday, and I wanted to finish talking what we were talking about. But we began by looking at the anatomy of the heart. We were looking at atria and ventricles, looking at the valve structures and noting that the valves are all one-way valves. Since we're going to go into the cardiac cycle now, remember that during diastole, the atrioventricular valves have to open. So the ventricle relaxes, pressure in the ventricle drops, and in fact may become negative as the ventricle kind of sucks in some blood. And that AV valve opens, the ventricle fills during diastole. During systole, that ventricle contracts, and we talked about the fact that the QRS complex is electrically associated with the mechanical contraction of the ventricles. And if I go back into diastole, the P waves in atrial contraction is going to occur during diastole of the ventricle, because the atrial kick is what helps that ventricle to preload. And it's got to have blood in it in order to have any sort of generation of pressure. So we said during systole we've got contraction and ejection of blood. So the cycle repeats over and over and over again until it doesn't anymore, in which case we're looking for a mortuary. Anyway, cardiac cycle. We go back to the concept of why blood flow occurs. It has to occur from a higher pressure to a lower pressure. Same thing with valves. Valves open and close due to pressure gradients, and like we said, these are supposed to be one-way valves. If they aren't one-way valves, blood is going to regurgitate backwards from, for instance, the left ventricle past the mitral valve back into the left atrium, and that blood is kind of stuck in a revolving door instead of being able to go out through the aortic valve in the aorta and generate cardiac output. So the valves have to be functional one-way valves. The other thing is that those valves have to open completely during the ejection phase. If they don't, that's going to be an increase in work of that chamber trying to push blood through a valve that doesn't open fully, and we'll talk about that more later. In order to get gradients, pressure gradients generated, there has to be ventricular filling. There has to be muscle contraction, so we have to have ventricular systoles. So we're going to look now at the rest of the chapter which describes the cardiac cycle. And I've redrawn this cardiac cycle just to suit my purposes on PowerPoint so that I have a decent sized slide to look at. So when we go from essentially top to bottom, the black little squares represent aortic pressure. And we'll see that aortic pressure increases and decreases, but generally speaking is very high. Well, that makes sense because we look at blood pressure that we've talked about. Arterial blood pressure is measured off the aorta. We're talking about pressures that might be in the range of 120/80, or in people with hypertension even higher. We drop down to the orangish looking line that's a constant or continuous line. It's looking at ventricular pressure, and for our purposes I want to think left ventricular pressure. So we're focusing now on the left side of the heart. The blue circles represent left atrial pressure. Those again go up and down, but they're much lower pressures than we were looking at in either the aorta or in the left ventricle. The pinkish purplish, I guess I'm a little colorblind, line that's next is ventricular volume. And we talked about the heart having to get volume. It has to load the chamber with blood in order for volume to be expressed from contraction. So we've got a preload is the term we're going to use before we can eject blood. And then last on the bottom, of course, in the green is the electrocardiogram. So we're going to be looking at the electrical activity that causes mechanical things to occur during different phases of the cardiac cycle. Now when we look across the x-axis from left to right, we're looking at a period of ventricular systole. We said systole is when the muscle is contracting. Ventricular diastole, when the ventricle is relaxing and refilling, and electrically it's going to be reset to a baseline so that it can be prepared to contract again. And then we're going to go back through ventricular systole. So these are the things that we're going to be looking at different phases of the cardiac cycle. We said electrically it's going to begin at the SA node. The SA node is going to fire. We're going to get a P wave, which is that little green bump that we see in the electrocardiogram that is electrically associated with contraction of the atria. So when we look at contraction of the atria and we go up to our blue little dots here, we see that when the atria contract, pressure goes up. And when pressure goes up, we're going to be squeezing on the blood that's in the atrium, and we're going to be emptying some of that blood, if you want to think of it that way, then on the left side of the heart is going to be emptying down through the mitral valve, and it's going to be going into the left ventricle. So when we look at our purple tracing of ventricular volume, we get some emptying of blood from the atrium into the ventricle, or let's think about ventricular filling that's passive, and then the atrial kick, if you think about it, essentially tops off the ventricle. It gives it the rest of its filling. And then as we follow along, we're going to get to the period of systole. So we have on the green ECG, we have a downward Q wave, an R, and an S. So we're going to follow that atrial contraction with a ventricular contraction after the ventricle has been loaded. So after we've loaded the ventricle, the atrioventricular valve closes. So since we're talking about the left side of the heart, that left side valve between the atria and the ventricle, again, is the mitral or bicuspid valve. It's going to close during systole. So the ventricle is contracting. We're looking at ventricular pressure. This orange line, ventricular pressure, increases dramatically. And it's the pressure in the ventricle that's going to cause that atrioventricular valve to close. And if it's a competent valve, it'll close completely. So we've got a little bit of a drop in ventricular volume. You can see that our purple line has gone from a higher volume to a slightly lower volume because the ventricle is now contracting. But this portion of this cardiac cycle is called isovolumetric contraction. There really isn't any change in ventricular volume. No blood has left the ventricle yet, but it is compressed slightly by contraction of the ventricle. So like we said, the AV valve is closed, the ventricle is squeezing, but blood isn't leaving yet. And the reason why blood isn't leaving yet is because the aortic valve has yet to open. So when we look at this green bracket here that we're looking at, this is the change in pressure that occurs in the ventricle from the time the AV valve closes to the end of the isovolumetric contraction. So there's a dramatic increase in pressure during this portion of systole. The reason why we have ejection is because finally the pressure in the ventricle it exceeds the pressure in the aorta. So if the pressure in the left ventricle is higher than the pressure in the aorta, it opens the aortic valve. So when it opens, blood essentially gushes out into the aorta. So we have a period where there's a dramatic increase in aortic pressure along with ventricular pressure, and then we have a drop in both of those pressures. And we get to the point where the actual pressure in the aorta is higher than the pressure in the left ventricle. So the concept again is if blood is going to flow from higher pressure to lower pressure. But at this point in a competent aortic valve, If blood tries to go backwards to go from the from the aorta back into the left ventricle, that aortic valve should slam shut. And that's the second heart sound that we hear in the lub-dub sequence. Now, if people have abnormalities of the valves, they may have a delayed heart sound, they may have a third heart sound, they may have a heart murmur if the valves are not working properly. So another whole part of doing patient assessment is listening to the heart sounds during the cycle. But anyway, we're at the end of the ejection phase when the ventricle has decreased its volume dramatically. Remember, we went from this isovolumetric portion to during ejection when there's a dramatic decrease in ventricular volume because blood is rushing from the left ventricle out into the aorta. We're looking at ventricular pressure continuing to drop, and it finally drops to the point where it's gotten the atrial pressure, even though it's passively increased, the atrial pressure now is higher than the pressure in the left ventricle. And I'm just going to go back for a second. As we see during systole, the pressure in the atria is just gradually creeping up in those little blue dots. It's gradually creeping up because blood is continuing to come back in the form of venous return. It's coming back to the atria. And if we're thinking about the left ventricle, it's coming from the lungs and the pulmonary veins back to the left atrium. So we have a passive increase in pressure in the left atrium as blood comes in. And then remember, when the ventricle completely relaxes during diastole, there may be a very low pressure in the ventricle that actually sucks some blood in from the atrium. And when that happens, we have a pretty significant drop in atrial pressure because we're offloading blood from the atrium into the ventricle. So again, we've got a situation where when the AV valve opens, blood is going to go from the atrium to the ventricle, and we're going to begin to preload the ventricle for the next cardiac cycle. So when the AV valve is open, and this is mostly a passive situation of filling, we're going to have a gradual increase in volume, which is our purple line again, of the left ventricle, because blood is going from the atrium and preloading the ventricle, getting it ready for the next systole. So again, in a nutshell, that's what happens over and over and over again as our heart continues to beat. So we're going to look at factors that influence cardiac output. We know that you've got to have a properly functioning pump, but you also have to have preloading, and you have to have a normal vasculature to pump this fluid into. So the term we're going to use for that loading again is preload. Preload means it's before contraction. So we've got to get volume into the ventricles. So the AV valve has to open. There has to be adequate venous return, either from the vena cava, preloading the right side, or from the pulmonary veins in the lungs, preloading the left side of the heart. But you have to have blood that enters those ventricles in order for it to be able to generate a stroke volume. I want you to think about afterload is everything that the ventricle has to push against to eject blood. And I'm going to use the example of Eric. Eric's a hockey player. He's a weightlifter. He goes to the gym and he works out. And if I set him down at the bench press and I put, say, 300 pounds on that bench press on the bar, Eric's going to ask me which arm to use. I said, go ahead, you can use both arms. But when he starts to push, he's pushing against the resistance or the impedance of that weight. If I put another 100 pounds on that bar, I've increased his afterload. And it's going to be harder for him to eject that weight. So afterload is everything the ventricle has to pump against. Contractility is essentially the inherent force that ventricle can generate. So we're looking at a value that's actually independent of preload. Now we're going to look at the relationship between preload and force in a second, but I want you to think about contractility as just the innate ability of that muscle to generate force. When we talk about receptors, if we try to improve contractility, there are drugs that we can give that are going to stimulate inotropic receptors. So an inotropic response is an increase in contractile force. And when we increase rate, this is synonymous with when we looked at minute ventilation, that minute ventilation is equal to rate times tidal volume. Cardiac output is equal to heart rate times stroke volume. So when we look at rate and receptors that would respond to a drug that increases heart rate, those receptors are called chronotropic receptors. So if you look at this very expensive watch I've got on my wrist, it was I think $25 before it went on sale. It says it's a chronometer. Okay, chrono means time. So chronotropic stimulation increases heart rate. Now when we look at preload, we said preload is related to the volume that we've put into a ventricle before contraction. So we've got to get volume in there before it contracts. The Frank-Starling law of the heart is really related to what we were talking about earlier in this semester with any muscle. If you pre-stretch a muscle, you lengthen that muscle. When you lengthen it, it can generate more force or tension. And the same thing is true when we look at the heart muscle. Heart muscle is muscle. We've got to get volume into the ventricle. We've got to pre-stretch the ventricle in order to get some force or tension generated. So we see from the shape of this curve that the more preload we put into the ventricle, in fact, I'm just going to grab my little pointer. I'm going to try and draw some stuff. The more volume I put in terms of preload, I must need a different color pointer. In color, let's go with red. The more volume I put into that ventricle, the more tension I'm going to be able to generate. Up to a point. There's going to be a maximum amount of tension that this heart can generate from a given amount of preload. If I overstretch the heart muscle and I put too much volume in there, which happens in some cases when we have patients who have fluid overload, maybe because their kidney doesn't work and get rid of fluid, they're going to have a drop in the tension that that heart can generate. By the same token, we've got some real aerobic types in this class that probably go out and run marathons. Those marathon runners by the end of the race are probably pretty dehydrated. They may not get as much preload then into the ventricle. The ventricle can generate less tension. Now, like I said, the force that's generated due to preload we want to think about as separate from pure contractility. Separate, you want to think about those things completely separately. But we know that all of these four factors are going to manipulate cardiac output. So what I want you to do is listen, think carefully about the cardiac cycle, think carefully about these factors that are going to manipulate cardiac output, and then we're going to look at things in more detail. Because we said we've got to look at the force that this ventricle can generate based on contractility, also based on preload, the impedance that it has to eject against. Those are three major factors that we manipulate in the critical care unit and also with exercise. And then obviously heart rate has a whole lot to do with our cardiac output. So when we pick up class on Wednesday, I want to start looking at the second section on cardiac function.